Well, thank you everyone for tuning into our symposium that will discuss heterogeneity in neurodevelopmental disorders, including identification, nosology, and intervention. Traditional psychiatric nosology characterizes individuals into distinct groups based on symptom profiles according to DSM criteria. However, there's a growing appreciation that within diagnostic groups, there is a large amount of heterogeneity, and that it's critical to understand this heterogeneity to be able to inform and improve targeted treatments. And this is why, of course, the RDoC initiative within NIMHS emerged, along with the nascent field of precision medicine. This figure nicely summarizes what we can learn when we characterize heterogeneity across levels from genes to endophenotypes about systems for treatment targets on an individual level. The talks in the symposium will address a range of issues related to understanding heterogeneity within and across diagnostic boundaries as related to neural and behavioral features of typical and atypical development. First, Lucina Uddin will discuss heterogeneity within and across highly comorbid neurodevelopmental disorders, autism spectrum disorder, and ADHD. Next, Adam Miller will talk about transdiagnostic risk factors for suicidal ideation and behaviors. And then I will talk about how we can leverage heterogeneity in functional brain network organization to shed light on differing response to treatment for ADHD. And finally, Jessica Church will discuss methodological considerations when assessing symptom burden and response to intervention in youth with ADHD symptoms and learning difficulties. By the end of the symposium, we hope that those of you listening will appreciate the importance of characterizing brain function and dysfunction related to cognitive and clinical heterogeneity so as to better understand the mechanisms underlying this heterogeneity, as well as the promise that this approach has for the development of personalized treatment strategies. Thank you.
Hi, thanks for joining us at this first time ever virtual OHBM. And I wanted to also say thanks to Jessica Cohen for organizing this symposium. I'd like to talk to you today about some of our work on parsing heterogeneity in prevalent neurodevelopmental disorders using executive function profiles and individual connectome mapping. Traditional diagnostic classification schemes are increasingly recognized as imperfect predictors of etiology and treatment response. Alternative systems, such as the Research Domain Criteria, or RDoC, are now focusing on the full range of variation in behavior across clinical and non-clinical samples, rather than using the case control approach. And the idea here is that we can perhaps find more homogeneous subgroups using markers such as brain activity or behavioral processes to parse heterogeneity and thus arrive at data-driven clusters of more homogeneous participants. Autism spectrum disorder, ASD, and attention deficit hyperactivity disorder, ADHD, are characterized by considerable phenotypic heterogeneity and comorbidity. Recent attempts to parse heterogeneity within autism spectrum disorder and within ADHD have been fairly successful in identifying subgroups within each of these disorders. But of course, there's a high degree of comorbidity between ASD and ADHD, making this endeavor much more complicated, with some estimates as high as 85% comorbidity between the two disorders. As we were able to work with Stuart Mostovsky's group at Kennedy Krieger Institute to obtain a sample of children between the ages of 8 and 13 who have ASD. One subgroup had ASD, another with ADHD, another with comorbid ASD and ADHD, and a typically developing group. And here we're focusing on executive functions and cognitive flexibility deficits, which we know to be quite prevalent across both of these and other neurodevelopmental disorders. Most of the work I'll be talking to you about today was done by Dina Dejani, a graduate student who completed her PhD in our lab. And what she did first was a latent profile analysis, including behavioral indicators of executive function from the brief, so the subscales of the brief, and ran this LPA across the 4 groups of children that I showed you in the previous slide, and found evidence for 3 executive function profiles, or 3 executive function classes, one with average EF abilities, one with above average, and one with impaired. Interestingly, though, these EF profiles did not recapitulate diagnostic categories. As you can see, there were children with ADHD and the above average, in the average and impaired EF group, and there were children with autism in both of these groups as well. So since these executive function classes do not strictly reproduce diagnostic categories, this indicates that our current diagnostic labels may not map, or we already knew they don't map distinctly onto behavioral profiles. Adriana Baez was able to replicate this finding of three executive function classes in a group containing just typically developing children and children with ASD in an independent sample. We also know that deficits in executive function are associated with a range of other socio-emotional problems. In both of our studies, we found that in the impaired executive function group, regardless of diagnostic category, these children had higher problems in aggression, attention, social deficits, and uh, anxiety and depression. And this was also found in the replication sample that attention and social abilities were more impaired in the impaired executive function group. So the next question we had was, do children who fall within these three behavioral executive function classes exhibit differences at the neural level? So here we stratified the samples in three different ways. One, using traditional DSM-based diagnostic categories, typical development, ADHD, and ASD. A second analysis that grouped the children taking into account comorbidity between ASD and ADHD. That sample comprised a fourth group. And finally, we looked at grouping by executive function ability. So looking at those three executive function profiles. And we're interested in large scale brain network functional connectivity differences between these subgroups identified in three different ways. So we use dual regression independent component analysis to compare functional networks across these groups. And these are some of the networks that were derived from the ICA. We focused our attention more on the anterior and posterior default mode networks, or medial frontoparietal networks, the left and right central executive networks, or lateral frontoparietal networks, and the salience network, or the mid-cingulate insular network here. Surprisingly, we found that the subgroups of children identified by the executive function ability, irrespective of diagnostic label, did not exhibit differences in functional connectivity metrics, nor did the subgroups identified according to the traditional diagnostic labels. So this work actually suggests that neither traditional diagnostic categories nor subgroups derived from behavioral profiles clearly define neurobiologically separable groups. And so the nosologies that are reliant on behavioral data alone may not lead to the discovery of neurobiologically distinct categories. So the last few studies I mentioned were using behavioral rating inventory of executive function, which is a parent report measure. But we know that performance-based measures of executive function and informant-based measures can tell us different things. And there have been quite a few tasks developed for use in the executive function literature in cognitive neuroscience. The problem is trying to equate tasks that can be done in both adults and children and compared developmentally, as often these tasks have high working memory loads. And we know from decades of cognitive neuroscience literature that cognitive processes such as salience detection and attention, working memory, switching, and inhibition are all part of what enables cognitive flexibility and executive function more broadly. And we do know that both lateral frontoparietal network nodes and mid-cingulate insular network nodes are very important for these types of high-level functions. So what we tried to do in the lab is, for the last few years, develop a task that would be able to assess executive function across developmental samples and across clinical and non-clinical populations. So we took the flexible item selection task and adapted it to the scanner environment. And this is a task where participants are simply asked to choose two items that go together. They may choose based on color, they may pick the two blue items, they may choose based on the identity of the object, so they may choose the cards depicting rabbits, they may choose the number of items on each card. And each time this tests the ability to flexibly group items. And of course, when moving this into the scanner, we had to come up with a control condition that's visually matched and for motor responses. So here we just asked participants to follow along and press the buttons that are highlighted here. So they would press these two buttons highlighted in black, followed by the next two buttons, followed by the next two buttons, which gives us a nice control. So we've done this task in adults and found that it does engage the brain networks we expect to be involved in executive function. So what we did next was, oops, looks like we're missing a picture here, but we basically took the activation from those nodes in the flexible item selection task and used the peak activations as regions of interest in an effective connectivity study applied to the resting state fMRI data from the groups of children with ADHD, ASD, comorbid ASD and ADHD, and also the typically developing group. So we used group iterative multiple multiple model estimation, which is an effective connectivity approach developed by Katie Gates at UNC. And we did find evidence for, so this was an attempt to parse heterogeneity using neural markers and connectome mapping. And although we did find evidence for 3 subgroups within that mixed group of children, these were not stable or valid subgroups, and there was a lot of individual variability, as you can see in the connectivity profiles. So we did, however, find that there was a overall relationship between executive function as measured by the brief and connectivity between the left and right superior parietal lobule. So there was an overall relationship, but no distinct subgroups were noticed in this analysis based on brain connectivity metrics. So taken together, these studies suggest that ASD and ADHD must be considered in the context of considerable phenotypic heterogeneity. And we know that RDoC approaches, considering the spectrum of behavior and brain metrics across clinical and non-clinical groups, are now very much encouraged by funding agencies like the NIH. However, the studies that I've just shown you highlight the difficulties associated with parsing heterogeneity and neurodevelopmental disorders like ASD and ADHD. So what we suggest is that novel data-driven approaches must be developed to inform a revised diagnostic nosology. I'd like to thank my lab, the Brain Connectivity and Cognition Lab at the University of Miami, and our funding from the National Institute of Mental Health, and all of the collaborators and other researchers who helped provide data and code for these studies. And thank you for your attention.
Hi, everyone. I am Dr. Adam Bryant Miller, and today I'm going to be talking to you about within-person models and understanding risk for suicidal ideation and behavior. Suicide is the second leading cause of death among adolescents, both worldwide and in the United States specifically. This means that adolescents are more likely to die by their own hands than by any other medical illness. And these rates have stayed consistently high over the past several decades, representing a significant public health crisis. What we know about adolescent suicide is that there is a clear developmental onset to suicidal ideation and behavior. Suicidal ideation and behavior prior to the age of 11 is relatively rare. Beginning around the transition to puberty, rates of suicidal ideation and behavior increase exponentially, and they level off in early adulthood. Now, while we know a lot about risk factors for suicidal ideation and behavior among adolescents, one of the core problems that we face as suicide researchers is accurate prediction. Currently, with our state of knowledge, we're no better than chance at predicting when someone is going to attempt suicide or die by suicide. And as a good example of this, I'm going to talk about depression diagnosis. So, as is the theme in our set of talks, the predicting suicide is not easily done by understanding someone's psychiatric diagnosis. People with depression are at increased risk for suicide, but fewer than 3% actually attempt suicide, and even fewer die by suicide. So knowing someone's DSM diagnosis of a mental illness is not particularly useful in predicting when they're going to attempt suicide or die by suicide. In fact, adolescent suicide has been associated with just about every psychological disorder in the books. So if you know someone's psychiatric diagnosis, it does not give you too much information about predicting their future behavior. And I think this is illustrated if you were to look at the research literature on risk factors for suicide. You would see a collection of studies. In fact, the majority of studies talk about higher levels of a risk factor being associated with increased risk for suicide. And what those studies most frequently mean is that greater levels of a given risk factor relative to everyone else in the sample was associated with increased risk for suicide. So, this type of research, which predominates the literature, has been very useful in helping us understand correlates and risk factors for suicide. However, these are all sample specific statistics. And if you are a clinician in the community treating a caseload of chronically depressed or chronically stressed adolescents, knowing that higher levels of stress and depression are associated with risk is not particularly useful. So, I've been conducting a set of studies that's looked at how a person moves around their own typical levels of depression or stress, and wondering whether that might help increase our prediction accuracy of suicidal behavior. And in order to test this initial hypothesis that it's not mean levels of a risk factor, but more so how someone moves is higher than usual than their typical levels of depression, I conducted a study with about 220 adolescent girls who were increased risk for suicide. We assessed them at baseline and followed them every 3 months for 18 months. And at each assessment point, we assessed their levels of depression and their reported levels of stress in the past 3 months, as well as whether or not they had engaged in suicidal behavior. And for the sake of time, I'm just going to present the results on suicidal behavior. What we found in this study, contrary to the majority of research in this literature, is that higher levels of stress average, so compared to other people in the sample, did not actually predict suicidal behavior. We were not surprised by this because this is consistent with the idea that it might be more useful to see how a person moves around their own mean levels of stress. And in fact, when we look at that, we see that girls who were reporting higher than usual stress reported a greater likelihood of suicidal behavior. But uniquely in this sample, this was only true among adolescents with a history of abuse. Now, I don't have time to get into this other area of research, but this is consistent with stress sensitization work suggesting that early adversity makes individuals even more sensitive to fluctuations in stress. And importantly, we have replicated these findings in 2 independent samples, both with 3-month level data and also daily level data as well. So this is initial work to look at whether or not a person's own individual experience can help us understand and better predict suicide risk. However, not everyone responds to stress in the same way. And so, in another line of research, I've been looking at a transdiagnostic risk factor for psychopathology and suicide, which is emotion reactivity and regulation. Now, we know from some of our neuroscience research on emotion reactivity and regulation that the cognitive control of emotion, which is one type of emotion regulation strategy, consistently activates prefrontal cortex regions, and presumably in the service of downregulating subcortical activation. So, one thing that we also know from this line of research is that individuals who experience early adversity differentially recruit their prefrontal cortex regions in the context of emotion regulation. They basically are not as efficient at recruiting these prefrontal regions to support emotion regulation. So I wondered if we might also see differences in emotion reactivity and regulation in adolescents with and without suicidal ideation histories. We know from behavioral research that individuals with suicidal ideation report feeling dysregulated when they experience strong emotions. And so, an initial test of this hypothesis that adolescents with a suicidal ideation history would differentially recruit prefrontal cortex regions, I was fortunate to have data from about 49 adolescents who completed a well-known emotion reactivity and regulation task, which involves cognitive reappraisal when they're passively viewing negative stimuli. So in one condition, they see neutral pictures, in another, they see negative pictures. In the negative pictures condition, they either look at the pictures or use cognitive reappraisal. And so from this initial study, you can see here that individuals without suicidal ideation histories are bringing online their prefrontal cortex regions, and presumably in the support of emotion regulation, automatically. Whereas our kids with suicidal ideation histories are not bringing online these areas during passive viewing of negative stimuli. In contrast, when we tell them to actively regulate their emotions using the cognitive reappraisal techniques, we see that individuals with suicidal ideation histories are able to bring those areas online. And this difference between those two groups was significant. And in the prefrontal cortex, this region was the dorsolateral prefrontal cortex. But as a clinical psychologist, I'm most interested in whether or not we can predict future behavior. And so I've been very curious to see if some of these neural signatures may help us more accurately predict suicidal ideation severity in the future. So in the second study, to extend this initial study, I had data from about 123 adolescents who we assessed at baseline, and then we followed them up about 2 years later. In this study, we were interested to see whether the dorsolateral prefrontal cortex, as we independently defined it using the ROI mask from the original study that I just presented, could help us predict future suicidal ideation severity. And in fact, what we found, consistent with our hypotheses, is that reduced activation in the dorsolateral prefrontal cortex at baseline when they were passively viewing negative pictures accurately predicted future suicidal ideation severity about 2 years later. Obviously, we need to replicate these studies with larger samples, but this is initial evidence that we could predict future suicidal ideation severity and perhaps behavior with some of our neural markers of emotion reactivity and regulation. But what I'm most excited about is integrating both our within-person models that I was describing earlier with some of the more recent neuroimaging work that my lab has been conducting. And so I'm particularly interested to see whether or not we can identify increased periods of suicide risk. And I doubt very seriously that we're going to find one single brain mechanism that will help us do this. In contrast, I believe that we're going to need to get signals across a variety of domains. And here I've provided a hypothetical graph looking at sleep quality and cognitive control during periods of increased stress as potential markers or constellation of risk factors that increase suicide risk in the acute moments of a crisis. And so that is where I hope to extend this area of research to help us understand the rich heterogeneity underlying adolescent suicide. And with that, I'll take a quick second to thank my funding sources who've supported this line of research. Thank you.
So I'll be talking about a study we conducted in my lab where we observed that heterogeneity in functional brain network reconfiguration after methylphenidate administration in ADHD underlies individual differences in improvements in response control. As Lucina discussed in her talk, it's known that there is substantial heterogeneity in ADHD. First, of course, there's evidence for cognitive and symptom heterogeneity. As an example, this figure depicts different subgroups of typically developing on the top panel and ADHD on the bottom panel children based on cognitive profiles. And as you can see in the ADHD subjects, that there's a lot of variability across groups when it comes to patterns of cognitive deficits. There's also evidence for heterogeneity in brain function. And this figure depicts just one example of many. It shows that different subgroups of ADHD and typically developing subjects have different patterns of functional connectivity depicted by the different red and blue and gray arrows within the frontoparietal cognitive control network. And finally, there's heterogeneity in treatment response. So only 70 to 80% of individuals with ADHD respond to the recommended first-line treatment, which is methylphenidate, with many other treatments improving symptoms for a smaller percentage of patients. The connectome may be a promising candidate for successful prediction of treatment response. It's been found that baseline functional connectivity predicts treatment response across populations and interventions. As an example, in patients with traumatic brain injury, it's been shown that baseline whole brain modularity predicts improvement in attention and executive functions after cognitive training. It's also been shown in patients with obsessive compulsive disorder that baseline functional connectivity patterns within the default mode network and the visual network have been shown to predict reduction of OCD symptoms after treatment with cognitive behavioral therapy. And as a last example, in patients with schizophrenia being treated with antipsychotics, baseline connectivity within the default mode network, as shown in the red connections on the top panel, and then between the default mode network and salience and motor networks, as shown in the blue connections, have been shown to predict reduction in positive symptoms of schizophrenia after treatment. Therefore, the goal of the current study was to determine whether features of the functional connectome relate to improvement in cognitive control after treatment with methylphenidate in children with ADHD. Our participants were 24 medication-naive children with ADHD who were aged 8 to 12, and then 25 typically developing children who were age, sex, and IQ matched. The procedure involved 2 testing sessions approximately 1 week apart. For the ADHD subjects, they participated in a medication challenge. So this was double-blind, it was randomized, placebo-controlled, and crossover. And each subject received 0.3 milligrams per kilogram of their body weight of methylphenidate or placebo administered 1 hour before the MRI scan. For the typically developing subjects, they participated in 2 identical sessions with no drug or placebo. And then each session included a 12-minute resting state scan and a go-no-go task to assess behavioral response control. And in our version of the go-no-go task, as you can see, the subjects saw a series of sports balls on the screen, and they responded to each of the go balls, which were approximately 80% of trials. And then on the other 20% of the trials, they were no-go balls. So this tennis ball, for example, and they were told to withhold their responses to these no-go balls. We used standard pre-processing with fMRI prop and scrubbing of high motion time points with a frame-wise displacement greater than 0.2 millimeters. And subjects were excluded if fewer than 150 time points remained after scrubbing. The mean frame-wise displacement was equivalent across the 2 groups. They weren't significantly different. In terms of the regions of interest, we selected ROIs from an updated version of the Power Functional Atlas with better subcortical coverage. And we focused on networks that have been found to be disrupted in ADHD. So we looked at cognitive control networks, the frontoparietal and cinguloopercular, the default mode network, the reward network, and the somatomotor network. We calculated 3 different metrics to assess network topology. First, we calculated modularity, a whole brain measure that assesses the overall segregation of the brain into distinct modules or networks, depicted by these gray ovals. We also calculated within module degree, which is a nodal measure that characterizes the strength of within-network connectivity of a node. So this red node that I've circled in yellow, for example, has high within module degree. We assessed average within module degree across all nodes within a network to get network level averages. And this was how we assessed within network coherence. And finally, we calculated node dissociation index, also a nodal measure that characterizes the connectivity of a node, but this time outside of its network. So the blue node that I've now highlighted in yellow has high node dissociation index compared to other nodes in this graph. And once again, we average across all nodes within a network to get network level averages of node dissociation index to assess across network integration. On a group level, we found that methylphenidate significantly improved response speed, mean reaction time, with a trend toward improving accuracy or D prime. We found, however, that methylphenidate did not significantly improve response variability on a group level. And our index of response variability was coefficient of variation, or CVRT, which is calculated as the standard deviation divided by the mean reaction time to control for baseline differences in mean RT. However, if you look on the individual subject level, you see that there is a lot of inter-individual variability in terms of the magnitude of improvement on the task. So while many subjects do improve on drug, you can see that some stay about the same and others perform worse. So we investigated whether methylphenidate-induced change in network organization related to improvements in performance on the go-no-go task by subtracting both network metrics and behavior assessed on the drug day from network metrics and behavior assessed on the placebo day. And we focused on response variability, CVRT, and accuracy or D prime because these are metrics that are most consistently impaired in ADHD. So before I show any data, I'm going to show you the axes I use so it's clear what they're depicting. So for CVRT, for example, on the x-axis, I plotted the change in the brain metric. And so because we subtracted methylphenidate from placebo, positive values indicate that participants performed, or the brain metrics were higher in magnitude on the placebo day as compared to the drug day, and negative values that they were higher on the drug day. And then on the y-axis, I plotted the change in behavior, the change in CVRT. So here, positive values indicated that subjects performed better on the drug because this means that CVRT decreased on the drug day, or responses became more stable. and the negative values indicated that they performed better on placebo. And then I plotted the same data for D prime. The only difference being that because higher D prime indicates behavioral improvement on the drug is negative, and better improvement during the placebo session is positive. First, we looked at whole brain modularity, and we saw no relationship between change in modularity on drug and change in behavior for CVRT or for D prime. So next, we looked at the network level properties of within module degree and node dissociation index. When focusing on within module degree of the task relevant networks, we found with regards to CVRT that if within module degree of the cognitive control cingulo-opercular network decreased on the drug, then CVRT decreased. In other words, responses became more stable. We also found that if within module degree of the reward network decreased on drug, then D prime increased. So responses became more accurate in addition to becoming more stable. When probing node dissociation index of task relevant networks, we found with regard to CVRT that if the node dissociation index of the cognitive control frontoparietal network decreased on drug, then CVRT decreased or responses became more stable. And with regard to D prime, we found that if node dissociation index of the reward network increased on drug, then D prime increased. So subjects became more accurate with increased NDI of the reward network. So this study demonstrates that methylphenidate improves response control in some, but not all children with ADHD, that the degree of change in topology of task-relevant networks related to the amount of improvement in go-no-go performance. So we did not see that whole brain change in topology was related to improvement on the go-no-go task. However, with regard to cognitive control networks, we found that decreased within-network connectivity of the cingulo-opercular network and decreased inter-network integration of the frontoparietal network related to reduced response variability or reduced CVRT. And with regard to the reward network, we found that decreased within-network connectivity and increased inter-network integration of the reward network related to improvements in accuracy or increased D prime. So together, this indicates that we may be able to use network topology as a biomarker for methylphenidate response to ultimately better target treatments for individuals. And I just want to end by thanking, of course, all of the participants in this study, as well as each of my lab members, especially those who were part of this project. So Cheyenne Brookin, Kelly Ohm, Nick Fogelman, and Teague Henry. And I'd also like to thank my collaborators with those highlighted who were involved in the project, Diana Sajas, Laura Polite, and Margaret Sheridan. Thank you.
Hi, I'm Jessica Church, and I'm really happy to be talking as part of this wonderful symposium. So my lab is really interested in how children learn and how children maybe struggle through that process or experience learning difficulties. And we look at that through the lens of control systems in the brain, in particularly focusing on executive function skills, focusing mostly on inhibition, shifting, cognitive flexibility, and working memory, though obviously executive functions and control can be captured in a lot of different ways. But we also look at particular academic skills, such as struggling readers, and how they change over time, and whether control plays a role in their improvement. One of the things that we've really faced with as we worked with different groups is understanding how to categorize individuals when symptom burden or difficulties are kind of continuous in nature. So if we look at this distribution of attention deficit hyperactivity disorder symptoms and participants, you can see that while, yes, the purple, the undiagnosed kids are quite different from the diagnosed kids in green, there is a substantial amount of overlap in the middle. And that relates partially to the lack of mental health care access in the United States and the stigma associated with mental health impairment, and also a lack of awareness of difficulties, but also that attention problems exist on a continuum, and there's going to be people in the middle with and without that diagnostic label. If we look at parents' rating of children's ADHD symptom problems, primarily hyperactivity, impulsivity, and inattention, you can see that the ADHD diagnosed children are significantly rated higher by their parents on hyperactivity and inattention relative to undiagnosed children. However, if you look in that middle range there, you can see that there's a large degree of overlap. If you ask the children themselves about their symptom burden, you can see that that overlap gets even stronger and only the inattention symptoms are significantly higher in the diagnosed individuals, though, the overlap is really substantial. So it can depend on who you ask, how many different ratings you get of individuals, what type of comorbid measurements you get. And so we think that, thinking about the importance of diagnosis and recognizing that as an important criteria, but also thinking about assessing continuous levels of symptom burden in the population are important to consider. And also who you ask about those symptoms and those problems and how many different tests or ratings you acquire per person. So I'd just like to go into two examples today from my lab, both work of Tahila Nugel, a talented graduate student in the lab. The first looking at ADHD and hyperactivity and inattention symptoms and whether or not they're consistent across different executive function tasks. And the second in struggling readers and how we define improvement when children are noisy in individual measures of reading over time. Okay, so just to start with the ADHD study, as Dr. Uddin presented already, there are multiple domains of executive function, and you might get different profiles of individuals that are impacted in different ways. And indeed, while you look at ADHD, if you start to test more broadly, you do see a higher incidence of executive function difficulty in children with ADHD and a wide-ranging degree of impairment. However, most imaging studies only use one executive function task, typically from the inhibition domain. So that's something to consider. We wanted to test the consistency of symptom impact across 3 different executive function tasks. And so to ask whether inattention and hyperactivity symptom burdens co-varied with bold activity in the same way, and did ADHD symptom burden consistently impact the same brain regions across different tasks? Did it impact that core set of control regions that you can see here, the kind of frontal parietal and cingulo-opercular brain networks? So we use 3 different tests of executive function, trying to tap into different aspects of control. Cognitive flexibility, we used a cued switching task between shape and color. A working memory task, we used a very classic standard NBAC task, looking at the 2-back, more challenging version here. And then for inhibition, we did a very classic stop signal task as well. And so we then took the individual ratings, parent ratings of hyperactivity and impulsivity and inattention, and asked whether those showed consistent patterns across the brain and whether the patterns of impact were consistent across the 3 tasks. And in short, we did not see a consistent effect. So we did see some impact in control regions for cognitive flexibility, as well as sensory motor. But we did not see that in the working memory task. We saw a default ventromedial prefrontal cortex impact of both hyperactivity and inattention symptom burden. For the inhibition task, we saw a different effect again, a negative relation to hyperactivity symptoms in a posterior cingulate precuneus type of region. And so we did not see an impact on a consistent set of core control regions, and we did not see a very consistent impact of inattention symptom burden versus hyperactivity symptom burden. All right, so we think that this is interesting, but what happens if you look at the diagnosis group themselves? If you compare diagnosed kids to undiagnosed kids, we see only the working memory effect in the same ventromedial prefrontal cortex regions, but we lose out on some of the nuance of the cognitive flexibility and inhibition task. And so this suggests to us that these continuous symptom burden level approaches are a little bit more sensitive, especially when the 2 sample groups are somewhat overlapping in symptom profiles. All right, turning to struggling readers, it is relatively easy to identify struggling readers from non-struggling readers on basic reading measures. However, it is more challenging to define improvement over time because not every child responds to the same reading intervention in the same way. So we decided to test whether a gain or growth approach over time at the individual level would be more sensitive or informative than using a cut score kind of approach or a median split approach. So let me explain what I mean. So for this work, I'm talking about my work with the Texas Center for Learning Disabilities, which is hoping to promote better reading skills for all of Texas's children. And this particular study looked at struggling readers in 3rd to 5th grade compared to grade-matched non-struggling readers. And they were tested in the fall, including with an MRI scan. They then went through the spring of their school year and some reading intervention, and then were tested post-test again in the summer. And so from this time point to end point, we can then ask, okay, who improved and who didn't over time? And to do this, we used a growth approach. So we looked at what their expected gain would be for the school year and looked for children that exceeded that gain, so that we could then go back and say what was different maybe in the brains of those children. And so you can see there is a non-improver profile where they did not gain on any test above what would be expected for their age, and then an improver profile. And these can look quite different across individuals, but we decided to pool them in a way if they gained at least on 2 out of 4 different reading measures. Okay, so now this is our label of improver and non-improver. We can then back sort to the pre-intervention imaging data and say, are there any differences in the brain of future improvers versus future non-improvers? Because there's no behavioral difference at that time point. They seem on paper to be exactly the same. But we also wanted to compare that growth model label of improvement to more traditional measures of improvement, such as a cutoff score of one particular reading measure, for example, like the tower. So saying kids who are above 90 are going to be called improvers versus below 90. And you can see our coloring of our gain-defined improvers in red and our gain-defined non-improvers in blue, and that they're quite intermixed using this cutoff approach. Similarly, with a median split approach across the composite of all 4 post-test scores, we can just look at high scores versus low scores, but again, that doesn't capture the nuance seen in the gain approach in the orange versus the yellow here. Okay, so across all 3 approaches, we actually saw a consistent impact relative to non-struggling readers. So before intervention, these struggling readers did show a difference between non-struggling readers such that future improvers show greater negative activity in a default mode region on the left here, and future non-improvers actually showed deactivation of a frontal parietal control region in the right posterior temporal lobe relative to non-struggling readers. And this was consistent across all 3 approaches. However, where the gain approach won out is when we tried to compare future improvers versus future non-improvers. So behaviorally not different, but in the brain, we see a right fusiform related region that showed a difference using this gain definition, such that future improvers were engaging this right fusiform more than future non-improvers. And that was also seen after intervention, correlating with the amount of growth an individual experienced over the school year. So we feel like this gain approach gained us some nuance and subtlety that the cut score and median split approaches did not. So the take-home points from this talk today are just that studies need really careful consideration of symptom profiles, more nuanced than just diagnosed or non-diagnosed, perhaps. Multiple tasks or multiple measures of disorders or abilities can really reveal consistencies or lack thereof, such that we did not see that our ADHD symptoms impacted consistent brain regions across different executive function tasks. And the use of a great gain or growth approach, like Dr. Miller also said in his talk, at an individual level could be really important for intervention assessment. And in this case, in struggling readers, it may improve our sensitivity to detect those who go on to experience growth over time. So I'd really like to thank my lab, especially my graduate students and all of our funding sources. And thank you for listening.